Welcome back, everybody. So in this next video, we're going to talk about Alport syndrome. Alport syndrome is an inherited, typically X-linked condition that can present with a variety of different findings, including visual, hearing, and renal involvement. So if we look at our pathophysiology, we see that Alport syndrome is involving type 4 collagen. And this type 4 collagen defect is really what explains to us why we get so many different findings in these patients. And the reason is that our type 4 collagen is found in several different places in the body, including the glomeruli, the cochlea, and the eye. And this explains why we get this constellation of findings where we have hearing problems, visual problems, and a kidney problem. And consistent with all of our previous pathologies, right, anything that disrupts our filtration barrier or an irregularity in the glomerular basement membrane is ultimately going to affect our ability to filter the appropriate molecules. That is to say, damage to this barrier is going to create this scenario where we are filtering things we typically would not want to filter through the nephron. It's important to note that this is a progressive pathology. Early on, we have a fairly normal endothelium, glomerular basement membrane, and podocytes. Notice the thickness of this glomerular basement membrane. This is vital for helping us keep out substances we don't want filtered in the kidney. So remember, if this is our glomerulus, we typically have small molecules that can always filter through, like ions and water, but our larger molecules, our proteins, are typically not allowed to filter through. And part of that reason is there is a barrier, there's an obstruction in the way. So if this tries to get through, it cannot do so because of the barrier, and thus it's going to be continuously kept in the body. However, over time, because we have damage to our type 4 collagen, we actually start to see thinning and even splitting of the glomerular basement membrane. So if you look at this one over here, I've drawn this image to show that the GBM is much thinner and thus damaged. And a damaged GBM is not going to be as good at blocking some of the substances, so while it'll still allow water molecules and ions to get through, this thinning might make it so that our larger protein molecules, one of the key ones being albumin, are now also allowed to get through this barrier. And remember, this is a nephritic syndrome, so it's likely that we'd also see red blood cells making their way through the filtration barrier, leading to hematuria. So then if we were working up this patient, right, we're looking to make a diagnosis of Alport syndrome, one of the early initial tests you want to do includes a urinalysis. And the reason is that this is a very easy, quick, and minimally invasive test that we can do to gather a lot of pathological information about the patient. And so while urinalysis is a good place to start for working up this patient to see if they have signs of red blood cells or other things in their urine we would expect, the confirmatory test that we need to do is actually a skin biopsy. And the reason is because a skin biopsy, which would show the absence of collagen type 4 alpha chains. And remember, collagen type 4 is the one that we said is problematic here with these patients. Additionally, if you were to get a renal biopsy, you would see something called a basket weave appearance on electron microscopy. And you get this basket weave appearance because remember that the glomerular basement membrane is now abnormal and there's a combination of thin and thick components. Typically, this is something that they would describe to you rather than give you the buzzword of basket weave. They would describe it to you as this inconsistency of thick and thin changes under electron microscopy in the setting of a classic patient presentation, which might include a child who has been experiencing some kidney deficiencies in addition to some hearing deficiencies. And that combination of findings where you have potentially the eyes and the hearing and the kidney involvement is a classic triad for Alport syndrome. And as far as the management for these patients, it really is based on symptomatic management. As with a lot of these renal conditions, we're trying not to make things worse. And so you're going to regularly monitor renal function and you're going to treat the symptoms. You can use things like an ACE inhibitor or an angiotensin II receptor blocker for patients who have proteinuria. However, the only definitive treatment for these patients is to actually do a transplant. That is to take their kidney that has pathology and replace it with a healthy kidney. You can also consider treatments for the other conditions. If they're having hearing loss, we can use a hearing aid to supplement that, and they might potentially need corrective eye surgery if their symptoms progress enough. Some key associations I want you to keep in mind for these patients include one that we talked about at the beginning of this video, is that this is typically X-linked inheritance. I put typically because it is not always X-linked inheritance, but about 80% of cases are. Other times this can be an autosomal dominant inheritance or autosomal recessive. The other key association I want you to be mindful of is that it can present with intermittent gross hematuria. This is important, right? Because this typically presents in a child. And a child having hematuria is very unusual. Sometimes patients who have Alport syndrome can actually develop hematuria as early as infancy. And because this is such an unusual finding, it's one of the key associations that will make that connection. So if you're getting a 2-year-old presenting red blood cells in their urine, or a 7-year-old or a younger patient, right, that should be making you think of these types of pathologies versus a 65-year-old, right? There's a lot of other things that can be going on. They could have cancers, they could have all kinds of things. But for a child, which is when this pathology classically presents, right, because it is an inherited condition, and typically inherited conditions can present earlier in life because you're born with them, right? And that's why I want you to be really mindful of this finding. hematuria in a child, an infant, I want you to think about Alport syndrome. And finally, the classic triad of symptoms include visual symptoms such as retinopathy, hearing symptoms such as sensory neural deafness, and renal involvement such as glomerulonephritis. A classic memory aid for this condition is can't see, can't pee, can't hear a bee. And that includes our visual involvement, our renal involvement, and our hearing involvement. And so if you can remember this kind of memory aid, it keys you into what is the triad of symptoms that you're looking for in a patient's presentation. So in summary, the key things I want you to take away from this video is that in Alport syndrome, you have a type 4 collagen defect. Sometimes for memory aid, I call this Alfort, and calling it Alfort has helped me kind of remember that this is a type 4 collagen defect. The diagnosis can include our general workup of a urinalysis, but a unique thing that you can do is a skin biopsy, right? Because we know our skin is full of collagen. So if we can see that a patient is lacking this type 4 collagen, or they have a deficiency in it, that could give us further confirmation that we might be dealing with Alport syndrome. The management options here include symptomatic management. So you're treating the symptoms as they come in. If a patient has proteinuria, you're treating that. If they have hearing deficiencies, you're helping to treat that. And likewise, if they have visual disturbances, you're also going to try and help and treat that. The only definitive treatment is to get a kidney transplant. And because this typically presents in a younger age patient, this is likely something that they may ultimately have to have done. The key associations I want you to think about here include its most common inheritance pattern, which is X-linked, although it's not always X-linked. A hematuria in an infant or a young child is a very unusual thing. So if you see intermittent gross hematuria in a child, I want you to think about Alport, and then to remember this memory aid about you can't see, can't pee, can't hear a bee. This reminds you of the classic triad of findings in these patients, which you have visual disturbances, hearing disturbances, and renal involvement. Why are all these organs involved? Because all these organs have type 4 collagen, and thus a deficiency in that molecule is going to cause problems for a variety of different organs in the patient.